Hello everyone, this is Ali of the Pediatric Residence at Texas Tech, and today we're going to be talking about bronchiolitis. Bronchiolitis. You'll see it almost every single day. Not almost, actually, you'll see it every single day during your residency. You'll see millions and millions of patients. So I thought it's a good, nice, simple topic to talk about in feeding also some misconceptions about bronchiolitis that you'll see in some practices. You need to understand more about the literature review on the topic and go from there. So basically, bronchiolitis is an inflammatory disease caused by a viral infection, most probably, in patients less than 2 years of age, and affects their bronchioles, right? Yeah. Okay. So you'll have those patients come in, and you need to understand one of the most important things to know about bronchiolitis is bronchiolitis is a clinical diagnosis. You have a patient that fits the criteria for bronchiolitis. He's a young patient with a lower upper respiratory tract infections that turn into lower respiratory tract infection symptoms, who is at day 3 to 4 or 5 of illness, fits a viral profile. I don't need to do anything more than it. The most common causes of admission in a patient with bronchiolitis will be, this patient needs rehydration, or this patient needs oxygen. So when thinking of it, since it's a clinical diagnosis of a patient that just presents with runny nose, congestion, and dry to wet cough, you need to understand the peak of the disease in a way. So usually the most common cause of it is RSV, and when we talk about RSV, they will tell you usually it gets sicker at 4 to 7 days of illness. However, when we talk about human metapneumovirus or adenovirus, they will tell you that these viruses might have an earlier peak of symptoms around the 2nd day or so. And some of them have some other consular symptoms. For example, adenovirus can cause conjunctivitis and bilateral acute otitis media. Metapneumovirus is also one of those vicious viruses that you'll see can cause a high rate of hospitalization. So knowing the day of illness is one of the important things when getting a history about bronchiolitis patients, to understand the course of disease and what to expect for this patient to recover. It's also very important to tell the parent that these patients will be admitted for only supportive care, that these patients will have that dry cough last for maybe weeks, and we do not want to give them any specific medications to treat the cough in itself, like cough suppressants or expirants, because it might cause more harm than good, and it's not clinically proven to actually help anything. So if it's a clinical diagnosis, do we need to do a chest x-ray? No. Do we need to do a chest x-ray even if it's a pneumonia? No. It's a clinical diagnosis unless you're suspecting something else, unless the patient is not improving after giving them supportive care within the expected duration of improving, unless the patient spikes in new symptoms, respiratory distress worsens, the patient requires higher modality of oxygen support, like we discussed in a different topic of respiratory support. This patient started to spike higher fevers after that wave is done. You're suspecting some bacterial superadded infections, which also is not an indication for chest x-ray unless it's really worsening of that symptoms. And then the most common thing for these patients to be admitted for, as we said, is hydration. So what happens is basically these patients get very congested, and we know that these kiddos are nasal breathers and mouth breathers, and if they very much congested, they're going to start dependent on their mouth to breathe, and they'll have decreased PO intake. They will feel very fatigued and very tired. They get very irritated, and that will aggravate the causes of dehydration in these patients. That being said, so when you admit these patients for dehydration, which is the first thing we'll talk about here, is what should I give these patients? What's better? Should I give them parenteral nutrition, or should I give them enteric nutrition? And there are studies that shows all way, and most of what I'm saying is about Cochrane reviews, where they did multiple studies, and they reviewed all of these studies, and they just posted their primary outcomes and secondary outcomes. So they said, okay, so we have enteric breathers, and they said enteric breathers is more physiological, it's more beneficial, it's more using the guts. The problem with them is if you put an NG tube in and these patients are nasal breather, then you're obstructed 50% of what they're using to breathe. 2, older kids will be highly irritated by that NG tube, and they might be more lenient to remove it and poke it and anything else. However, it's actually less invasive than you think, with lesser side effects and more physiological outcomes, and more nutritious feeding, which also feeds into the improvement of these patients if you're measuring their respiratory coefficients and you're measuring their total caloric intake for that day, or their resting caloric expenditure, and you know that these patients' nutrition will benefit a lot if you're giving them enteric. Parenteral, the big problem is when it's an invasive procedures, or if parents think of it as less invasive than the NG tube, it's suboptimal in giving those calories. So let me make it more central. Let's do this. Oop. So parenteral and enteric. We said enteric is more physiological. However, it obstructs when it comes to nasal breathers, and it's a problem for older kids. When we're talking about parenteral, it is giving you suboptimal calories. It's giving you, it cannot keep up with the high catabolic state that these patients are in secondary to their respiratory distress, right? And then increase IV associated adverse event. Knowing this firsthand, putting an IV in a pediatric patient is very, very stressful. Even with the most experienced nurses, it's a very, very stressful procedure. The parents are stressed, the patient is crying, the patient is more liable to pull the IV, you have to hold down the patient. And higher adverse events of IV, whether infiltrations, infections, or removal of multiple pokes, which is basically pain, and also increases the probability of electrolytes disturbances. And remember that when you give that patient either D5NS or sodium chloride, you know that you're causing that metabolic acidosis as well in these patients. You need to be aware of what you're giving them to that extent. That being said, so that comes with the nutrition part, okay? Then we'll talk about the, let me erase this. I need to find a more efficient way to erase this board. Which I can use this actually. Anyway, so next thing we will talk about is, okay, what about bronchodilators? Can I use those bronchodilators or not? Does it help or not? Giving albuterol to these patients, does it help or does it not help? Albuterol, bronchodilators. Two things. You have to understand what's the process of bronchiolitis. Bronchiolitis is an inflammatory process in the lower respiratory system of the bronchioles. Is it a problem in the bronchospasm? No. Are there something called viral wheezers? Yes, there are viral wheezers, which are something called atopic viral wheezers. And these are patients that respond to bronchodilators. However, that being said, It's not mainstay of treatment to use albuterol or bronchodilators in patients with bronchiolitis. Okay, so when they did the whole study, they looked for, in the Cochrane review, they looked for primary and secondary outcomes, and the primary outcomes was oxygen saturation. Right, will that patient oxygen saturation improve or not? And then the duration of oxygen supplementation. And their secondaries was, okay, what's the length of stay in the hospital? What about the clinical respiratory scoring? What about the need to begin with to hospitalize these patients? And then last is length of illness at home. And they found that bronchodilators does not change any of this. Yes, there's always a transient VQ mismatch after giving bronchodilators, which will cause that dipping in the oxygen, which they also mentioned in the studies, but they never saw any change in outcomes in patients that from the gate started with bronchodilators. Does it decrease admission? Does it decrease going to the ED? Does it decrease length of illness at home? None of that was shown to proven based on the primary or secondary outcomes of those Cochrane reviews. Because again, think of it, these respiratory muscles are still immature around the lungs. That's to begin with. Second, it's an inflammatory disease. It's not a bronchospasm disease. And then, big problem with patients less than 2 years is their respiratory compliance. Their chest wall compliance is all over the place. You'll see them having that flail kind of chest movement once they're in respiratory distress, because they still does not have that rigidity of their chest to help kind of coordinate the external pressures on their lungs. So that being said, next point was, what about hypertonic saline, the 3% nasal saline? Does it make a difference? Does it help with anything? So they saw that hypertonic saline basically hasn't proven, if you give it out of the gate, to improve outcomes. However, in certain patients, which you're assuming that they have this thick secretions, that they said, oh, it decreases some of that length of stay. It does decrease initially the clinical respiratory score, and at times it helps decrease the hospitalization from outpatient ED. That being said, they said, oh, there's a higher risk with 3% to cause that bronchospasm, and that the 3% is better studied with cystic fibrosis, because it absorbs that water and causes all of that. So they said 3% hypertonic saline is not one of the mainstays of help. You will use it in those bronchiolitis patients that have prolonged length of stay, that might need PICU admission, come in with a bad respiratory status. You give it once or twice, and you'll see that initial improvement, but they haven't shown that a long-term effect of 3% hypertonic saline in any of those patients. Then they spoke about steroids. Does steroid help? And they discussed, okay, let's do this. What about if I used dexamethasone plus inhaled racemic epi? Does it help? And the only thing they found that it changes things with or helps with is it decreases hospital admission by 7th day of illness. Did it change the length of illness? No. Did it decrease the admission for patients that are already extremely sick? No. Did it decrease the length of illness at home? No. The only thing it said is by day 7, patients improved. However, if we already know, they were not sure whether it's because of the dexamethasone or the inhaled racemic epi, or is it because basically that's the clinical course where the patients get worse day 3 or 4 and improve about the 7th day of illness. then they said, okay, what about CPT? Patients come in, we do chest physiotherapy, that helps, that moves away the gunk in the lungs, and it will improve. Okay, they said, okay, there's a conventional CPT. They said there's something called a slow passive expiratory CPT. And they said, oh, there is a force passive X. And they said, okay, so patients with mild to moderate disease benefited from the forced expiratory plus the conventional in only one trial where there was 13 patients. And they said, okay, the mild to moderate one, if you use the forced passive with the conventional, on admission, you'll see immediate relief and improvement. However, they said, if these patients are only use the forced passive, you'll see that it will actually increase respiratory destabilization, and it will increase bradycardia, and it will increase DSATs, and there is a higher chance of mucus plugging. So they said neurotypical patients that have good cough reflex, let them do it. Those patients with prolonged hospitalization, not neurotypical, staying in the PICU, patients with thick secretions, let's use CPT, see if it helps. Let's do a combination of them to get good airway clearance. But if you're going to use them on normal patients, you actually might predispose to worsening of the clinical symptoms. And think of it this way: if you're using passive or forced or any CPT, you are dislodging, you are vibrating the lungs, and might dislodge more and more of those mucus plugging, causing more atelectasis in the patient and also causing more stress and agitation to these patients. Remember, one of the things when we're treating bronchiolitis, we want to keep those patients relaxed, calm. If you can control their agitation and their respiratory effort, if you can give them this enough oxygen support until they get over their clinical course, and if you can adequately meet their caloric intake, these patients will have good prognosis. Okay, and then they mentioned, okay, what about once the patients come in the room, regardless of their severity, can I use just pressure mode supports, the CPAP? And they only, I think, compared CPAP versus like normal oxygen support, whether it's, again, we said high flow, low flow term, which is basically simple nasal cannula. And they didn't find any change based on primary outcomes that we discussed initially, which is oxygen saturation, need of oxygen, duration on oxygen support, length of stay at the hospital, clinical scoring, need for hospitalization, anything like that. They said it didn't change from the gate about the severity. However, you pick your oxygen support modality or your respiratory support modality based on the severity of the patient, and you assess for it. And then two last things they kind of spoke about, which was interesting, which vapotherm. Should I put patients all on vapotherm? Because basically what we're talking about, this is a heated, humidified, high flow oxygen delivery mechanism. Would they benefit from it? And what they said, okay, so if you give those patients vapotherm, they see that you give them heated and humidified, it helps decrease their secretions, gives the patient spare support, give the patient spare flow, and it gives them those at times unreliable pressures that we discussed about before, PEEP pressures, which we discussed it was not reliable in multiple sources, where some of them mentioned, oh, it gives you 0.7 PEEP pressures per 10 liters. Some of them said, no, it gives you 6 to 20 centimeters of water pressures for every 8 to about 15 liters. And they said it's unreliable. We're not using it for this reason. Where again, they were all based on the clinical judgment of the assessing physician of the needed vapotherm benefit in bronchiolitis patients is because it's heated, humidified, and it gives you that high flow, and you can always give it the 2 liters per kg. At some hospitals you see that 1 to 1.5 liters per kg, because they say if you reach that 2 liters anyway, you might need that increase to a different high flow. And the reason where that number came, 2 liters per kg, I think they did more of trials and errors, and some emergency medicine physicians will be more relieved that once they see the patient, they just put them in 2 liters per kg. Others try to go escalate based on whatever the respiratory effort of the patient is. And what studies have shown is anything more than 2 liters per kg is not basically helping more with your oxygenation. Your oxygenation demand is not met, but is basically saturated at that liters. And if you still are as hypoxic, then you'll have to change a different modality, which is usually a pressure support modality. And then the last thing they kind of mentioned was they talk about heliox in these Cochrane reviews, and they said, okay, what they found is if the patient is already on pressure, and if the patient is maybe on CPAP, they did that trial with CPAP, did they see that that patient lasted on a lesser length of treatments and decrease that clinical respiratory support. And the reason why, because heliox promotes more of that linear upper airway airflow, which you'll see more with those bronchiolitis patients or those croup patients, where it just those linear flows help more delivering of that albuterol or that racemic epi. But in these patients, I guess maybe that laminar flow, or that linear flow helps more these patients with taking breath versus that resistance that they have with the increased secretions. But they only mentioned it with CPAP, and I haven't seen them use it separately otherwise. So that's basically a small brief talk about bronchiolitis, and I know most people say, oh, okay, this is a bronchiolitis patient, suction the patient, suction the patient, suction the patient, and I will tell you this, the most important things in those patients, as I mentioned, control their agitation, control their respiratory breathing, control their oxygen support, give them the nutrition that they need, and make sure that the nurses suction that patient every 2 hours or as needed to make sure that all the secretions are cleared, to create more comfort and for that breathing of those patients. I hope you guys benefited. If there's anything more that you guys know about the topic, please share. I'll put in the resources as usual down in the descriptions. Let me know if there's any misinformation that was said. Always read the disclaimer. Always let me know if there's anything that we can improve. And I'm pretty sure in the future we can use more improvement on such topics once anything comes out for us. Okay, thank you guys.